All right. Good morning, everybody. I'm Christina. I'm one of the pediatric nephrologists. I am here to introduce Ahmed Zeid, who's going to be giving our grand rounds today on nephrotic syndrome. Dr. Zeid joined us in 2024, almost exactly 2 years ago to the date. His bio is a little less than adequate, in my opinion, so we'll go off label a little bit here. But he earned his medical degree in 2002 from Cairo University. And then he did his postgraduate medical training and residency for PEDS and fellowship at Cairo University Children's Hospital. And then he came to the United States and did his pediatric nephrology fellow at Nationwide Children's Hospital and joined us in 2024. One of the best things about, I think, working in academic medicine is the dissemination of ideas and the sharing of ideas from different experiences from all over. And we have been so lucky to have Ahmed join us and bring new ideas and fresh ideas that help kind of progress, I think, the way that we practice medicine and bring novel things to our system. So it's my pleasure for him to share a little bit about nephrotic syndrome with you, and we greatly appreciated his arrival.
Hi, good morning, everyone. Okay, so our topic today is about nephrotic syndrome in pediatrics, okay, because I will talk about the congenital nephrotic syndrome and also in older children. Okay, so this is the outline for my presentation. Okay, so can I remove this? Okay, so this is the outline. Okay, so we'll start with the definitions and criteria for diagnosis. Yes, yeah.
Might come back if someone joins in, but it might not.
Okay. Okay, so I'll start with the definitions and criteria for diagnosis. Then I will talk about the mechanism of proteinuria, edema, and hyperlipidemia. And then later about idiopathic nephrotic syndrome of childhood, the age between 2 and 12. And so with some important definitions regarding steroid resistance and steroid sensitivity. And then I will talk about the immunosuppressive medications that we use, biopsy indications, different genetic causes, congenital nephrotic syndrome, and some specifics about its management, and then nephrotic syndrome recurrence after transplantation. And then if we have time, I will present some cases. Okay, so idiopathic nephrotic syndrome or nephrotic syndrome in general, it's an uncommon childhood condition. So the annual incidence in the United States is around 2.26 per 100,000, okay? And there was a study that was done in Atlanta, Georgia, and there were children of different ethnicities, okay? So it was found that the incidence was higher in Asian children and lowest 1.83 in Caucasians. And so studies from other parts of the world confirm this finding that the incidence is higher in Asian children compared to Europeans. And so there were no studies on the incidence from Africa. Okay. These are the criteria for diagnosis. So heavy proteinuria. So meaning that in children we use random urine samples. Okay. So the criteria for diagnosis would be urine protein to creatinine ratio. It should be above 2 milligram per milligram. Okay. Or if we collect urine in 24 hours, it should be above 1 gram per meter square. And of course, in the clinic, we use the dipsticks, so it should be 3 plus or more. Hypoalbuminemia, so now, based on the latest guidelines, serum albumin below 3 gram per deciliter is enough to be considered hypoalbuminemia. In the past, they used a different cutoff of 2.5. And edema, okay, so classically it starts in the periorbital area, feet, and dependent areas, okay? And of course, I will talk more about that. Okay. So mechanism of proteinuria, okay? So in general, we have two types of proteinuria, tubular proteinuria and glomerular. So tubular proteinuria occurs when there is tubular damage, there will be decreased reabsorption of filtered proteins, okay? Glomerular proteinuria will occur if there is podocyte damage or loss of charge selectivity, okay? So in glomerular proteinuria, it's primarily albumin loss, okay? So this can be a method to differentiate. And there's something more that we can say about that. So in minimal change disease versus FSGS. So minimal change will have more albuminuria compared to FSGS when there's podocyte damage. Okay, so podocytes are specialized epithelial cells that line the outer surface of the glomerular capillaries, and they have the food processes, which are cytoplasmic extensions. And these lie on the basement membrane, okay? And they form the slit diaphragm, okay? So these are the food processes, the slit diaphragm and the basement membrane, okay? And so the slit diaphragm proteins include nephrin and podocin, okay? And whenever there's a stress to the podocyte, this structure prevents normal regeneration, okay? So podocytes can regenerate in certain situations, like in children or after an acute kidney injury. And progenitor cells residing among the parietal epithelial cells are used for regeneration, okay? But most of the time when there's loss of one podocyte, there is an adaptive cellular program, okay? There is an increase in the basal level of autophagy, okay? And autophagy here does not mean cell death. It means clearance of misfolded proteins and damaged organelles, okay? And the other thing is compensatory hypertrophy in the podocyte itself, okay? And this is actually the mechanism of injury in hyperfiltration, okay? Okay. So, mechanism of proteinuria, okay? So pathologically, there are different types, okay? So the most common in childhood nephrotic syndrome is what we call minimal change. So here there is no podocyte loss, okay, but there is flattened or food processes, okay? And loss of the normal structure of the food processes. Focal segmental glomerulosclerosis, so there will be progressive and chronic podocyte depletion that exceeds the regenerative capacity, leading to scarring, okay? So this is here the FSGS, okay? So in diffuse mesangial sclerosis, there will be damage, okay, and the mesangial expansion, this will be the most remarkable thing, okay? So in collapsing glomerulopathy, there will be rapid and extensive podocyte loss, but as you can see here, it looks crowded, okay? This is because of regeneration of the parietal epithelial cells, but it's not actual, okay, because there is no basement membrane to regenerate upon, okay? So, and the other thing is, the other type is membranous nephropathy. So this is immune complex deposition, and it's in the subepithelial space among the glomerular basement membrane. And so these areas are not important for the podocyte function, but the mechanical stress and the complement activation will lead to damage, okay? So for the edema, okay, so there are two hypotheses for the development of edema, underfill and overfill. Okay, so this is, so the underfill, it means drop in the capillary oncotic pressure, okay, so the fluid will move from the capillaries to the interstitium, and so this will lead to hypovolemia, release of hormones, activation of the renin-angiotensin-aldosterone system, and release of vasopressin, so salt and water retention, okay? So this is the classic mechanism, okay? So overfill hypothesis, I mean, we see other patients with renal impairment, okay, or renal inflammation, glomerulonephritis, okay. And the overfill will mean salt and water retention, secondary to reduced filtered load of sodium, okay. So in classic nephrotic syndrome, there can be primary sodium retention, okay, due to increased activation of the epithelial sodium channels. And there's another slide about that, okay. So I'm discussing the mechanism of edema because in certain situations it will be important to differentiate, okay, what type of edema is it, okay, because the management will differ. Okay, so in simple terms, okay, so this is the revised Starling equation. So the older Starling equation, in simple terms, it's the difference in the hydrostatic pressure minus difference in oncotic pressure, okay? But the difference in hydrostatic pressure is multiplied by the hydraulic permeability coefficient, and difference in oncotic pressure multiplied by the reflection coefficient, okay? Which is a reflection of the permeability of the substance, okay? So when it's 1, it means it's impermeable. When it's 0, it means it's completely permeable, okay? So in the revised Starling equation, they found that using the oncotic pressure at the endothelial surface layer will be more accurate than using the oncotic pressure of the capillary itself, okay? And oncotic pressure at the subglycocalyx more accurate than using oncotic pressure of the interstitium, okay? Okay, and this point is very important, okay? So we know that, okay, so there will be a difference in the capillary oncotic pressure versus interstitial oncotic pressure. So the fluid will move from the intravascular compartment to the interstitium. But then what? Okay, will it keep moving forever? No, actually there will be an equilibration, okay? So there will be a parallel decrease in the oncotic pressure of the interstitium compared to the capillary pressure, okay? So this will happen because when the fluid will move, so the concentration of the protein in the interstitium will decrease, okay? And some of the protein will be reabsorbed from the lymphatics, okay? So this means that at stable condition, kids with nephrotic syndrome will not be always hypovolemic, okay? Okay. So in this slide, okay, so this is the general mechanism for salt and water regulation, okay? So we know that whenever the arterial pressure drops, okay, or the central venous pressure drops, there will be sympathetic activation stimulation, okay? Okay, so the sympathetic nervous system will lead to vasoconstriction of the renal arterioles, more the afferent arterioles more than the efferent arterioles, okay? And it will lead to sodium retention in the proximal tubules and the ascending limb of loop of Henle, okay? And it will lead to renin release, okay? And there are other things, okay, that can promote renin release, okay, so decreased sympathetic stimulation, decreased sodium delivery to the macula densa, decreased blood pressure, okay, these will lead to renin release, okay. So because it will feel as if the patient is hypovolemic, okay. So renin release, of course, renin will aid in the conversion of angiotensinogen to angiotensin 1, and angiotensin 1 will be converted to angiotensin 2, and angiotensin 2 will lead to, has a direct effect, will lead to systemic vasoconstriction, will lead to aldosterone secretion, and will cause actual sodium retention in the kidneys, okay? So aldosterone, it will lead to sodium retention. It acts via the mineralocorticoid receptors in the principal cells, in the collecting ducts. And and this will occur via the epithelial sodium channels and the basolateral sodium ATPase. Okay, so the counter, so first, okay, so whenever there is increased plasma osmolality or decreased blood pressure, the vasopressin will be released, okay? And the vasopressin will lead to increased sodium reabsorption, okay? And the action is mediated via the V2 receptors, okay? And this will lead to the activation of aquaporin, okay? So the aquaporin are inserted in the Prinzmann cells, and this will lead to water reabsorption, okay? So the counter-regulatory mechanism here is the atrial natriuretic peptide, okay? And this is released in response to atrial stretch, secondary to blood volume increase. And it will try to stop the aldosterone release, decrease sodium retention in the kidneys, and will counteract the action of the aldosterone on the tubules. Okay. So there were actual studies that were done to measure the blood volume. These were done in the past to measure the blood volume in patients with nephrotic syndrome, okay? And as I said, at baseline, okay, the blood volume is only slightly lower compared to normal persons, okay? So they have hypovolemia, maybe with rapidly developing edema, okay? Or there are acute fluid losses. Okay, so diuretic use after paracentesis, diarrhea, vomiting. Okay, so consequently, if you check the levels of the hormones, the sympathetic hormones, renin and aldosterone, they shouldn't be high all the time at baseline. Okay, these will only point to actual hypovolemia, intravascular depletion. Okay? So what about the atrial natriuretic peptide? Okay, so it should promote natriuresis. Okay, so actually in kids with nephrotic syndrome, it's not, even if it is elevated, the response is blunted. Okay, and it was found that there is a reduction in choline. So choline is a transmembrane protein, and it's responsible for activation of atrial natriuretic peptide. So it cleaves the pro-atrial natriuretic peptide and brain natriuretic peptide, and produces the active form of the atrial natriuretic peptide. So it is reduced in kids with nephrotic syndrome, okay? And so the hormone that will actually be elevated will be the vasopressin, okay? And we can, we do not check the level of the vasopressin, but there's another molecule that we can check, okay, which is copeptin. It's more stable, and it's considered a marker of vasopressin release. Okay, so I did mention the aquaporins. Okay, so the action of the arginine vasopressin is mediated by the V2 receptors, and this leads to the insertion of aquaporins into the apical membranes or the Prinzmann cells and increased water reabsorption. Okay, so this will be important because some medications can be used for edema management in this patient. Okay, so again, so under normal conditions, so the aldosterone will act on the mineralocorticoid receptors within the Prinzmann cells or the distant tubules and collecting ducts, and this will lead to sodium reabsorption, okay, basolateral sodium potassium pump, as well as epithelial sodium channels. Studies actually showed that the epithelial sodium channels can be active in kids with nephrotic syndrome in a mechanism that is not related to aldosterone. Okay, so when there is proteinuria, okay, so many proteins are lost in urine, including plasminogen, and plasminogen can be activated by urokinase that is present in the tubular epithelium. And okay, so they actually measured plasminogen, plasmine in urine, okay, and they were found to be elevated in kids in patients with nephrotic syndrome. And so when we give an ACE inhibitor, this should decrease the aldosterone and it should promote natriuresis, okay, but actually this does not happen, which proves that there is another mechanism for primary sodium retention. Okay, so dyslipidemia. Okay, so kids with nephrotic syndrome, of course, can have hyperlipidemia, and this can be a differentiating finding. Okay, so if you have a child with low serum albumin, okay, so we think is this loss in the urine or somewhere else. Okay, so if someone with protein losing enteropathy, for instance, they will have because of the fat malabsorption, they can have low lipid levels, okay? But in kids with nephrotic syndrome, they should have hyperlipidemia, okay? So all the levels are elevated, the cholesterol, triglycerides, apolipoprotein B. And so the mechanism is decreased clearance and to some extent increased biosynthesis. Okay, so decreased clearance means decreased lipase activity in the liver, hepatic lipase, and decreased lipoprotein lipase in the adipose tissue and muscles. Okay, and so the other thing, the increased free fatty acids will lead to increased triglycerides and increased immature HDL. Okay, and the HDL is important for the calcium efflux. Okay. Meaning that the HDL will not be active, okay? So it will worsen the percentage of bad fat, bad lipids, okay? So, of course, lipid nephrotoxicity, because, I mean, with the hypercholesterolemia and increased LDL, there will be a risk for atherosclerosis, cardiovascular disease, thromboembolism. And of course, this is more likely to occur in kids with steroid-resistant nephrotic syndrome, okay? So idiopathic nephrotic syndrome of childhood, okay? So I'm talking about the age range between 2 and 12, okay? So these kids, in most of the time, they are, it's primary, so it's idiopathic, not secondary to another disease, okay? So nephrotic syndrome is a clinical presentation, okay? So when I'm talking about idiopathic, it means the one that is not secondary to an underlying disease like lupus or vasculitis. So for idiopathic nephrotic syndrome of childhood, the incidence, yeah, so I said in the US, it's 2.26. And so the cumulative prevalence is 16 per 100,000 children, also in per year in USA and Europe. So sex difference in this age range, it's more common in males. Sorry. But there's equal incidence in adolescents. Familial prevalence, of course, kids with steroid-resistant nephrotic syndrome. So there will be more likely to be, other cases in the same family because there's probably a genetic cause. Okay. Okay. So in many cases, before the onset of the nephrotic syndrome, there is a trigger, okay? And in most cases, it's not an actual cause, but it will trigger the immune reaction that will lead to the presentation of nephrotic syndrome, okay? So it can be some allergy, okay? So some flare for an allergy, some pollen, fungi, cow's milk, okay, bee stings, okay? Some drugs like nonsteroidals, ampicillin, and malignancies like Hodgkin lymphoma and bronchogenic carcinoma and colocarcinoma, which are not common in kids. So with Hodgkin lymphoma and non-Hodgkin lymphoma, the usual pathological finding is minimal change, meaning only effacement of the food processes, and treatment of the malignancy will lead to resolution of the nephrotic syndrome. Okay. And sometimes it can start after a viral infection or diabetes. Okay, so some kids with the onset of diabetes, they can present with nephrotic syndrome, and usually they respond well to steroids. Okay, and it will be minimal change nephrotic. Okay, And sometimes with myasthenia gravis, sometimes it can present after an immunization. Okay, so clinical presentation. So this is the usual age range between 2 and 7. And so, of course, it will be sudden onset of edema, and edema will be more clear if it constitutes 3 or 5% of the body weight. Okay, so periorbital dependent areas, and it should be soft and pitting. So there can be ascites, abdominal pain, malaise, and of course, abdominal pain in kids with nephrotic is an important symptom because there's, differential diagnosis for it. Okay, so it can be a manifestation of hypovolemia, can be peritonitis, medication induced because they will start steroids. Okay, and thrombosis. Okay, which is one of the complications. Okay. And of course, rapid development of edema can lead to cardiovascular shock. Okay, and so-called extremities and hypotension. Okay, so blood pressure in most of the cases is normal. Okay, so it will be low if the patient is shocked, can be low, or it can be elevated in a very small percentage. Okay, so it's unusual. And sometimes the disease can present with a complication like peritonitis or thrombosis. Okay, so lab results. Okay, so if we see a child with edema, we'll order tests. Okay, so urine and blood. So the urine, as I said, the criteria. Okay, so it will be 3 or 4 plus. Okay, above 2 milligram per milligram, the urine protein to creatinine ratio. And if we do a 24-hour urine collection, it will be 40 milligram per hour per meter square, which is around 1 gram per meter square per day. Okay. In most cases, proteinuria is highly selective, so albumin and low molecular weight proteins. And so I did mention that we can use, they try to use this to differentiate between minimal change and FSGS. So when it's mainly increased albuminuria, it's more likely to be minimal change when there's podocyte damage. So with FSGS, the percentage of other proteins will be higher. Higher molecular weight proteins, their percentage will be higher. Okay, so microscopic hematuria is acceptable. Okay, it's present in 20%. Gross hematuria, yeah, it can happen in 3%, but of course there is when we see it, it's kind of concerning. Okay, it makes us think about maybe vasculitis or lupus, so secondary causes of nephrotic syndrome, and it can be a manifestation of renal vein thrombosis. Okay, so we can fat bubbles in the urine. I've never seen this reported. Okay, but it is there. Okay, and of course hyaline casts if there is renal failure, and sodium excretion is low. We talked a lot about. Okay, and blood tests. Okay, so hyperalunemia, and of course all the binding proteins and the immunoglobulins will be decreased. Okay, so the IgG will be markedly decreased, IgM will be increased, and so there will be an increased risk for thrombosis. Why? Because fibrinogen will be increased, antithrombin 3 will be decreased, and the hyperlipidemia, we already talked about it. Okay, so two main causes for hyponatremia in kids with nephrotic. So pseudo-hyponatremia. Why? So with hyperlipidemia can interfere with the analysis for sodium. Okay, so sodium level can be artificially low. Okay, so how do we differentiate? We check the serum osmolality, okay, and compare it to the calculated osmolality. Okay, so if it's normal, then it means that the patient is not actually hyponatremic. Okay? And the same thing happens with kids with hyperglycemia, for instance. So. And of course, the hyponatremia maybe can be caused by the increased vasopressin, inappropriate ADH secretion. Okay, the calcium level will be low, but most of the time it will be the total calcium will be low because of the low serum albumin. This is why we should check the corrected calcium. So hemoglobin and hematocrit levels will be increased in patients with hypovolemia. Patients with nephrotic syndrome can develop actual anemia because of loss of hemosiderin and erythropoietin. And complications. Okay, so we did mention hypovolemia as a complication. So yeah, it's more likely to occur if there are fluid losses or with a severe relapse or with the first presentation, if it occurs suddenly, okay, or with infections after paracentesis. And by the way, paracentesis is always a bad idea in kids with nephrotic. And so the presentation will be abdominal pain, hypotension, sluggish circulation, okay? And if whenever there's decreased renal blood flow for a good period of time, it can lead to acute tubular necrosis, and it will predispose to thrombosis, okay? So acute renal failure can occur. So in most cases, it will be pre-renal, and it can be reversed with rehydration, and we'll talk about the rehydration. But it can be secondary to an infection, thrombosis, okay, bilateral renal vein thrombosis, or interstitial nephritis, any medications, maybe an antibiotic, okay? So infections can occur mainly because of loss of a complement component, factor B, loss of immunoglobulins, okay, and impaired lymphocyte function. So something that has to do with the T regulatory cells, and of course the immunosuppressive medication that we may give, okay, and the edematous tissues, okay. Pneumococcal peritonitis, spontaneous bacterial peritonitis can be a presentation, okay. Hemophilus infection, gram-negative sepsis, staph cellulitis, okay, and significant edema, okay. So graft failure can occur. Of course, it's more likely to occur in someone who did not respond to steroids. Okay, so it's because of loss of proteins, okay, definitely, and loss of insulin growth factor 1 and 2, and so hypothyroidism can develop. It's more likely to happen in kids with congenital nephrotic syndrome. And again, of course, it's because of loss of the thyroid binding globulin. So thrombosis. Okay, so many things predispose to thrombosis. We mentioned the low antithrombin 3, high fibrinogen, hyperviscosity, and hypovolemia. Any central venous catheter, immobilization, infection on this can predispose to thrombosis. So thrombosis is more likely to occur on the venous side. And so renal vein thrombosis, cerebral venous thrombosis, pulmonary embolism, okay. Of course, DVT, okay, deep venous thrombosis. And so it's more likely to occur in the first 3 months after presentation in older kids above 12 years of age. And yeah. Okay, so chronic renal failure. Yes, in steroid-resistant nephrotic syndrome, there is a 50% chance of developing chronic renal failure after 10 years. Okay, so in all kids with nephrotic syndrome, we do education, okay? So we talk about the diet, okay? So the main thing is salt restriction, okay, to all patients, okay? So of course, the salt requirement varies depending on age. So we'll see the age and we target a lower level, okay? And so good protein intake. So because they are losing proteins, so it is recommended to increase the protein intake a little, okay? So 130 to 140%, but not higher because more protein intake can predispose to more glomerular injury, okay? And of course, good caloric intake. So water restriction, this is not we don't recommend this to all patients. It's only in patients with severe hyponatremia. And of course, we recommend reduction of saturated fat. And we recommend starch, so complex carbohydrates rather than sucrose, because sucrose will increase the lipid abnormalities. Okay. So approach to assessment of edema. So I did talk about the intravascular volume contraction, hypovolemia, and intravascular volume expansion. Okay, so intravascular volume contraction uh, um, can present with some symptoms like orthostatic hypotension, tachycardia. Okay, so these patients are likely to have low urine output. Someone who has hypervolemia, intravascular volume expansion. So this can occur, kidney function is abnormal, okay, actually reduced GFR, or if there is kidney inflammation, someone with glomerulonephritis. And so someone with acute tubular necrosis, okay, so the urine output, yes, it can drop, okay. Kids with intravascular volume depletion are more likely to have increased sympathetic stimulation than and aldosterone. Some ways that we can use to differentiate is the serum sodium. Of course, it can be tricky because I did mention that many kids with nephrotic syndrome will have hyponatremia, but if we compare this level to the previous levels, we'll see that probably the sodium level will be higher if there is volume contraction. And so whenever there's intravascular volume expansion, there can be dilutional hyponatremia, so our sodium level will be low. So same thing for the hematocrit. Okay, so elevated hematocrit will probably reflect hypovolemia, and we see this a lot. Okay, so kids with hypovolemia, most cases, okay, if they don't have ATN, the urine analysis will be bland except for the proteinuria, of course. If there is an ATN or renal inflammation, glomerulonephritis, we are more likely to see cellular casts or hematuria. And some ways to differentiate is the urine sodium, okay? So very low urine sodium will point to hypovolemia, intravascular volume depletion, and increased urine sodium may actually mean that there is a tubular damage, okay? And may point to increased volume expansion, okay? And another method to differentiate is using the urine potassium over urine sodium and urine potassium, okay? So urine potassium will be high if there is aldosterone release, more aldosterone, okay? So high urine potassium over urine sodium and urine potassium will point to hypovolemia, okay? So yeah, urine potassium will correspond to serum aldosterone, so both should be high if there is hypovolemia. Of course, all these numbers will be affected by the medications. So if we're giving ACE inhibitors or ARBs, okay, will affect the levels of these hormones, and diuretics will mess up all this picture, okay? Okay, so yeah, so I mean, some studies, they try to look for other ways to assess the intravascular volume. So echocardiography, okay. So yeah, they did a study and they compared patients with nephrotic syndrome before and after remission, okay, and they found no difference. But I did mention that patients with nephrotic syndrome at baseline, they do not have hypovolemia, okay. So it's only with maybe severe relapse or when there are fluid losses, okay. So I still think that point of care echocardiography, checking the IVC diameter can help assess the intravascular compartment. So bioelectrical impedance, okay. So this measures the total body water and intracellular body water, okay. So this is not very helpful, okay, because it will tell you that the total body water is increased, okay. So yeah, we can see that, okay, but it will not differentiate between the different compartments of extracellular water, okay. So is it intravascular or in the interstitium, okay, it will not tell us, okay. Okay, so I did the management of nephrotic syndrome. So of course, the main management is the steroids, okay, and I mean, if they don't work, of course, we will have to start immunosuppression, okay? But there are other measures. We did talk about the diet. And so maintaining activity, we do some family education. So they should monitor the urine by dipstick, blood pressure, daily weight, avoid nephrotoxic medications. In some cases, we do start ACE inhibitors or ARBs to decrease the proteinuria. Usually, we do that in kids who do not respond to steroids. And of course, we can use diuretics or albumin or aquaretics. And okay, so we have two situations, okay, hypovolemia or hypervolemia. So when I say hypervolemia, it means more total fluids, okay? So this can either be intravascular or extravascular. So if it's intravascular, we'll just give diuretics, okay? Like furosemide, spironolactone. Of course, all these can cause electrolyte disturbances. Aquaretics actually can be used to promote water, only water diuresis, okay? And so most of the time in children, we do not like to prescribe diuretics on their own for management, okay, because there is a risk of hypovolemia. In kids who have distressing edema, okay, we can use albumin and Lasix or very low doses of diuretics, okay? And of course, we use the albumin, the 25% or 20%, okay, and followed by Lasix. Okay, so kids with hypovolemia, so those with intravascular volume depletion, tachycardia, hypotension, we give 5% albumin. Okay, of course, this is preferred than giving IV saline because IV saline will just diffuse into the interstitium. This is the roadmap for all kids with nephrotic syndrome. So less than 12 years, no syndromic features, no family history. We will give steroids, and this is the dose, 2 milligram per kilogram for 4 to 6 weeks. Okay, so after 4 weeks, there's 2 weeks, we call it confirmation period. Okay, so we can either give 3 doses of methylprednisolone, okay, and on 3 consecutive days and see if there's a response or not. And or we can continue for another 2 weeks, okay? If there is no response, so we will label these patients as steroid resistant and we'll consider doing a kidney biopsy genetic testing, and we will start an calcineurin inhibitor and an ACE inhibitor. So here they say referral to specialty center because in other parts of the world, okay, nephrotic syndrome is managed by the general pediatrician. Okay, so in kids who are over 12 years of age, those with syndromic features or positive family history, we do genetic testing and biopsy from the start because it's unlikely to be responsive to steroids. Okay. So after 4 or 6 weeks, if we achieve complete response, okay, we will taper the steroids, okay, so the total duration will be either 8 or 12 weeks. So these are important definitions. So complete remission, meaning that the urine protein to creatinine ratio will be less than 200 milligram per gram within 4 weeks, or if the patient is late responder, so respond after 4 weeks, okay, but before 6 weeks. And this should be maintained for 3 consecutive days, okay? Partial remission, meaning that it's not nephrotic range, but it's still above normal, okay? So less than 2 milligram per milligram, but over 0.2 milligram per. And so relapse is recurrence of the nephrotic range proteinuria for 3 consecutive days. So steroid sensitive response within 4 weeks, infrequent relapse, 2 relapses in the first 6 months or less than 3 in a whole year. Steroid dependent, having 2 consecutive relapses while on steroids within 15 days of stopping. Late responder, so 4 to 10% response within the confirmation period. Frequent relapse, 2 or more relapses in 6 months or 3 or more relapses in any subsequent 12 months. Steroid resistant failure of response within 4 weeks. okay, or 6 weeks, okay? So the percentage of steroid resistant varies in different parts of the world, okay? So it's in the northern hemisphere, it's believed to be around 10%. I found a study from Africa, and they say it's around 20%. In where I come from, okay, 30%, okay? Okay, so medications used for frequent relapse and steroid dependent, okay? So levomethasone, it's an immunomodulator and antihelminthic, okay? So it has some side effects, neutropenia, rash, some neurological symptoms like insomnia, hyperactivity. And so the effect is maintained as long as the patient is taking the medication, okay? And according to the KDIGO guidelines, all the medications we give for steroid dependent should be given at least for 12 months. So another option is cyclophosphamide, oral cyclophosphamide for 8 to 12 weeks. So it's known for the side effects of bone marrow depression. Okay, this is why we should monitor the CBC every 2 weeks. Okay, hemorrhagic cystitis and alopecia. Okay, if given for the long-term toxicity is post malignancy, pulmonary fibrosis, and ovarian fibrosis and sterility. Okay, so the risk of sterility is higher in boys, and it's more likely to occur after a cumulative dose of over 200 milligram per kilogram. Okay, so yeah, it's believed to, I mean, some studies showed that cyclophosphamide can sustain remission in 57 to 90% of patients at 1 year. Calcineurin inhibitors, okay. So these inhibit the synthesis of interleukins, which are essential for self-activation of lymphocytes and proliferation. So we start with a certain dose, and then we decide on the dose based on the drug level, and this medication should be given, of course, on time every 12 hours. So same thing, it should be given for at least 12 months. So of course, it has many side effects, like nephrotoxicity in many ways. So it interferes with the myogenic response. So it can cause impaired kidney function if the patient is severely dehydrated. It can cause hypertension, hyperkalemia, some cosmetic problems like hair overgrowth, gum hypertrophy, and press. Okay, and because of it is the metabolic, it's an inhibitor of cytochrome P450, so it interacts with many medications, which is so it decreases the incidence of relapse by 75 to 90%. Both cyclosporin and other calcineurin inhibitor tacrolimus are believed to be more effective compared to mycophenolate. But the problem is that most patients will experience relapses when the cyclosporin is withdrawn. Okay, so tacrolimus, another calcineurin inhibitor, it has most of the side effects, cyclosporin, but it doesn't have the cosmetic side effects, and it's more likely to have to cause tremors, headaches, or glucose intolerance. Okay, and of course there will be the same problem with the drug interactions, and it's probably as effective as cyclosporin. So mycophenolate, again, it depletes the guanosine nucleotide, essentially in T and B lymphocytes, so it will affect the proliferation of lymphocytes. Okay, so this is the dose, okay, and we do not check the level of mycophenolate regularly. We check it for questioning adherence, okay. There is an enteric-coated form, myfortic, and it's believed to have less GI side effects, but I mean, this is not certain because it's believed that maybe the action on the GI cells leads to the GI side effects and not just, I mean, the enteric-coated form will not prevent this. Okay? So GI side effects, okay, enteropathy can be a significant side effect, leukopenia, elevated transaminases, teratogenicity, and genotoxicity, meaning that there is a risk that even the male taking the mycophenolate may lead to fetal abnormalities, okay? Some studies have shown it to be less effective than cyclosporine and tacrolimus, but we will use it. So in actual practice, our first choice for steroid-dependent nephrotic is mycophenolate. We may think of using levamisole in frequent relapses. Okay. I mean, if the patient does not respond, then we start thinking of using calcineurin inhibitor. So for steroid-dependent, yeah, of course, rituximab, it's actually better than Sancerta in steroid-dependent and frequent relapses, but it's a heavy immunosuppression anti-CD20 monoclonal antibody monitored by CD19. So the dose is 1 to 4 doses every 2 weeks. So the guidelines do not specify the number of doses. Some centers they monitor with the CD19, and based on this, decide whether to give another dose or another series or not after 6 months. And the 1-year relapse-free rate average is 70%. And of course, the more the doses, the better the response. So in some studies, okay, the risk for relapse was higher if 1 dose was given. So average relapse rate was after 8 months, but after 2 doses, the average relapse rate was 17 months. Okay, so steroid side effects are pretty well known. Okay, but and this is why we use the other medications to try to avoid giving steroids for long periods. If we have to use steroids for long periods, like in steroid dependence, sometimes we use a lower dose. We should monitor the glucose and transaminases Q3 to 6 months, and we should do an eye exam for the cataract and glaucoma. For steroid-resistant nephrotic, so yeah, so the main line is the calcineurin inhibitors. Okay, glucocorticoids can be used in the confirmation period and then tapered. Rituximab, it's not recommended based on the guidelines, okay, but many studies show a remission rate around 46%. So kids with minimal change are more likely to respond to rituximab than those with FSCS, and kids who are late responders but then go on to be steroid resistant are more likely to respond to rituximab. And of course, rituximab should be given when there is no proteinuria, as much as possible, decrease proteinuria, else it will be lost in urine. Mycophenolate, so it's not very recommended in kids with steroid resistant, but it can be used maybe after many years of using calcineurin to try to avoid the side effects if the remission is maintained. Okay. So other medications, so abatacept, adalimumab. So maybe the abatacept is the only one that was actually had promising results in the studies. Okay, so it's so there's co-stimulatory ligand CD80. Okay, that is expressed on the surface of antigen-presenting cells and fundamental for binding of the T cell receptors. And so it's an inhibitor of this, the CD80, okay? And it has been used in patients with recurrent nephrotic syndrome after transplant. So the daratumumab, okay, so it was given in combination with the rituximab because it targets the plasma cells, okay? So another treatment modality is LDL apheresis. So clearance of the lipids will ameliorate the macrophage response and clear the cytokines, and it will increase the response to cyclosporin. And of course, it will clear the anticoagulant, the thrombotic factors, okay? So it is mentioned in the Japanese guidelines, and it was used before in refractory nephrotic syndrome and recurrent nephrotic syndrome after transplantation. So renal biopsy indications, we did talk about them, steroid-resistant, features of secondary disease, impaired renal function and those older than 12. So mechanism of podocyte injury, okay? So in children, there are 5 mechanisms, okay? So autoimmune, okay? So antibodies against the slit diaphragm proteins like podocin and nephrin, okay? Are more likely to cause minimum change or FSGS. Antibodies against podocyte antigens like the phospholipase A2 receptor are more likely to cause membranous nephropathy. And so genetic, yeah. So we did mention no, we didn't mention it now. Okay, so genetic defects in the slit diaphragm proteins like podocin and nephrin and other proteins in the slit diaphragm will lead to minimum change of FSGS, mostly FSGS. And so adaptive, okay, so it's either increased filtration need, like in obesity or hyperfiltration, like sickle cell disease. I will show you some of the examples. Or decreased filtration surface, okay, so reduced nephron mass, okay. So this will eventually lead to a minimum change of FSGS, okay. So some can be a toxic injury or infectious injury to the podocyte, like interferons, doxorubicin, tamidronate, sirolimus, okay. All these are possible causes for FSGS. And infections, okay, so the most famous of these are parvovirus B19, COVID, HIV, okay. So yeah, so these are examples for some of the drug-induced FSGS, like heroin, and I mentioned the sirolimus and tamidronate. And so for the secondary FSGS, so I mentioned reduced nephron mass. So, and this is actually the mechanism for the hyperfiltration injury that we always talk about, okay? So reflux nephropathy will lead to reduced functioning nephron, number of functioning nephrons, okay? And will lead to injury, as I showed in the slide before this one, okay? And very low birth weight, okay? Because these kids are born with low nephron mass, okay? And so hypertension or obesity or sickle cell anemia are examples of hyperfiltration injury because of increased increased filtration needs. Okay, so some genes associated with steroid-resistant nephrotic syndrome. So NPHS1, this is the gene for the nephron. Okay, it's more likely to cause congenital nephrotic syndrome. NPHS2 is more likely to cause, which is the gene for podocin, more likely to cause steroid-resistant nephrotic syndrome, so at an older age. And there are other genes like the phospholipase C epsilon 1 and coenzyme Q8, okay. APL1, of course, very known in African American, okay. So there are two genes, okay, G1 and G2, so homozygous or compound heterozygous. Patients, okay, are more likely to develop chronic kidney disease, maybe in over 20%, and so FSGS and hypertension, and actually a single gene mutation can predispose to hypertension. So there are some genetic causes, autosomal dominant genes that are responsible for steroid-resistant nephrotic syndrome, and these are some of the examples. For instance, the LMX1, which is the gene for nail patella syndrome, okay, so hypoplastic nails, so the alpha-actinine 4, this is, so it's a gene that leads to abnormal basement membrane, okay? And so, of course, the collagen AA3 and 4, so this is the autosomal dominant, okay, form of the thin basement membrane disease, okay, so it's a spectrum, okay, so, of course, I mean, it's beyond the scope of this presentation, output. Okay, so congenital nephrotic syndrome is nephrotic syndrome presenting in the first 3 months of life. And so between 3 and 1 year of age, we call it infantile nephrotic syndrome. And of course, in most of the time, it also is due to a genetic cause. Okay, so congenital nephrotic syndrome can be secondary to an infection. Okay, congenital infection or maternal SLE, neutral antibodies against neonatal antibodies against neutral endopeptidase. And so the finished type of congenital nephrotic syndrome is caused by the mutations in NPHS1, the gene for nephrin. And so one of the other common genes is the laminin beta 2, which causes Pearson syndrome, microchoria, and neurological abnormalities. I did mention the WT1 ambiguous genitalia, risk for gonadoblastoma or Wilms tumor, and Lowy syndrome. Okay, so these are just some examples. Okay, so kids with Finnish type nephrotic syndrome. Okay, so Finnish because it's more common in Finland, and so they are usually born prematurely, large placenta, large kidneys, present with edema, mild hypotonia, mild pulmonary stenosis. Okay. And for kids with congenital nephrotic syndrome, of course, we should start by excluding secondary causes. We should exclude hypothyroidism and keep checking thyroid levels. And of course, we should do genetic testing because this will make the difference. Okay. It will tell us about the prognosis, and this way we will look for other associated symptoms. Okay. So, yeah, so these are the general lines of management. Okay, so first, the nutrition, albumin infusion, medications. So it's mainly about decreasing the proteinuria to decrease the edema. Okay, anticoagulation, nephrectomy. Sometimes we do unilateral nephrectomy. If we do bilateral nephrectomy, we'll start the patient on PD. So most of the time, kids do well with the albumin infusions and ACE inhibitors. We should do bilateral nephrectomy if it's secondary to WT1 mutation, because there's a risk of development of Wilms tumor. Okay, and of course, if the patient is not in remission by the time the patient reaches an adequate weight, then we should do bilateral nephrectomy before transplantation. Okay, so recurrence of proteinuria after transplantation. So it's more likely to occur if there is in kids who have nephrotic syndrome not due to a genetic mutation. Okay, and the risk is 20 to 30% more likely to occur early. It's higher in children, those older than 6 years of age, because in those younger than 6 years, it's more likely to be due to a genetic cause. And it's diagnosed by biopsy. If we do the biopsy early, we'll just see minimal change. Okay, so food process effacement. And the treatment is plasma exchange and immunosuppression, LDL apheresis is, and immunosuppression, including steroids and rituximab. Okay, that's it.
I love the fact that you have cases. I'm sorry that we're not able to get to those. I will note, many people know this. 34 years ago, I married a pediatric nephrologist, primarily because I was hoping that a lifetime of tutoring, I would get to a day where I could look at renal physiology and say, oh, that is so easy. I'm still waiting for that day.